Thanks for sticking with us if you've watched the other two. Marijuana and the immune response. Because of the importance of the body's natural defenses against illness, principally the immune response, and preserving the health of the individual, reports of impairment of this vital function must continue to be carefully considered. There have been contradictory reports of impairment of this response in humans. The animal data, using generally higher doses, have consistently indicated definite suppression of the host animal's immune responses. In humans, even when there have been indications of a diminished response, it has not been found in all users, and the clinical implications are in doubt. As yet, there has been no epidemiological research undertaken to determine whether marijuana smokers suffer from infections and other diseases to a greater extent than others of similar lifestyle who do not use the drug. For present, this important question must be regarded as unresolved, and the evidence far from clear-cut. Chromosome abnormalities. There is no new evidence in this area. While there were early reports of increases in chromosomal breaks and abnormalities in human cell cultures, more recent results have been inconclusive. The 3 positive studies in humans that have been reported have decided limitations. All were retrospective, i.e. studies of those already using marijuana who were compared to non-users. Such variables as differences in lifestyle, exposure to viral infections, and possible use of other drugs, all known to affect chromosome integrity, could not be reliably assessed. In 2 of the studies, the aberrations observed were found only in a minority of the users. 3 other studies have done prospectively, i.e. before and after use, have been reported. All were negative, but the results could have been influenced by the fact that all the subjects had at least some prior experience with marijuana. It is possible that the baseline levels of chromosome deficits may have been elevated by later casual marijuana use, thus masking a drug-related effect. A team investigating the effect of marijuana smoke on human lung cells in laboratory culture has found an increase in the number of cells containing an abnormal number of chromosomes. Another investigator who previously reported a high proportion of cells in marijuana smokers with reduced numbers of chromosomes has more recently reported that the addition of delta-9 THC, the principal psychoactive ingredient of marijuana, to the human white blood cell cultures also resulted in an increased frequency of cells with abnormally low chromosome numbers. The implications of these findings continue to be uncertain. Overall, there continues to be no convincing evidence that marijuana use causes clinically significant chromosome damage. However, it should be emphasized this year as last that the limitations of the research to date preclude definitive conclusions. Alterations in cell metabolism. The implications of laboratory findings on the inhibition of DNA, RNA, and protein synthesis, all of which are basically related to cellular reproduction and metabolism, are still unknown. Adding delta-9 THC to various types of human and animal cell cultures has been found to inhibit DNA, RNA, and protein synthesis. No effect on DNA repair synthesis was found, although the uptake of the chemical precursors within the cells was reduced by half. The possibility that cannabis, or one or more of its chemical ingredients, differentially affects the cell metabolism and reproduction of cancer cells in animals was raised by earlier reported research. One aspect of the mechanism by which this may occur is an inhibition of DNA metabolism in abnormal cells, but not in normal cells. Okay, that right there is freaking mind-blowing, those of you who are paying attention and managed to sit through this far to part 3. But this is, at least this to me is saying that one or more of its chemical ingredients will affect your cell's metabolism, and the reproduction of cancer cells inhibited the DNA metabolism in the abnormal ones, but not the normal ones. And I assume the abnormal ones would be the cancer ones, in which case THC kills cancer cells. Yeah, that's pretty cool. And probably not something the government wants you to know. So if you made it this far, congratulations. Please leave a comment letting me know that you have been so enlightened. Because I had a theory, but nice to see it in a government document spelled out in black and white. An inhibition of DNA metabolism as a reduction in abnormal cells, but not in normal cells, and may shrink the tumors. If this preferential inhibition of DNA synthesis in animal tumors also occurs in humans, marijuana might prove of value as an anti-cancer drug. It should, however, once again be stressed that there is no evidence to date that cannabis or any of its synthesized or naturally occurring constituents is of value in inhibiting human cancer growth. If animal findings of a depressed cell immunity response, which is also related to cell metabolism, are substantiated in humans, cannabis, its synthesized components, or chemically related drugs might prove useful in preventing organ rejection in human organ transplant surgery. Yeah, I like how they're downplaying the cancer thing here, and sort of upplaying the like we could throw more organs into you and make you immortal. Okay, cool. Brain damage research. A British research report, which originally appeared in 1971, attributed brain atrophy to cannabis use in a group of young male users. In the original study, 10 patients with histories from 3 to 11 years of marijuana use were examined by air encephalography, a neurological technique used to detect gross brain changes. The authors concluded that their findings suggested that regular use of cannabis may produce brain atrophy. This research was faulted on several grounds. All of the patients had used other drugs, making the causal connection with marijuana use questionable, and the appropriateness of the comparison group and the diagnostic technique was questionable. The potential seriousness of the original observations justifies a brief review of several subsequent studies bearing on the original British observations. In a study of chronic Greek users, a different technique, echoencephalography, was employed to determine whether brain atrophy might be present in heavy users. The findings from the Greek study were negative, that is, users were not found to differ from non-users in evidence of gross brain pathology. 2 studies were subsequently conducted in Missouri and Massachusetts. They examined 2 samples of young men with histories of heavy cannabis smoking using computerized transaxial tomography, CTT, a brain scanning technique for visualizing the anatomy of the brain. In both studies, the resulting brain scans were read by experienced and neurodiologists, independent of the drug histories. In neither was there any evidence of cerebral atrophy, as was emphasized last year. However, several additional points should be stressed. Neither study rules out the possibility of more subtle, lasting changes of brain function may occur as a result of heavy and continued marijuana smoking. It is entirely possible to have impairment of brain function from toxic or other causes that is not apparent on gross examination of the brain in the living organism. Nevertheless, virtually all studies completed to date, late 1979, show no evidence of chronically impaired neuropsychologic test performance in humans at dose levels experimentally studied. A researcher who used electrodes implanted deep within the brains of monkeys instead of more conventional scalp recording techniques has found persistent changes related to chronic use. The same investigators reported that rhesus monkeys administered marijuana smoke from 1 joint daily for 5 days per week for 6 months showed persistent microscopic changes in brain cellular structure following treatment. While both these experiments demonstrate the possibility that more subtle changes in brain functioning or structure may occur as a result of marijuana smoking in animals, the implications of these changes for subsequent human or animal behavior are at present unknown. Other studies using more conventional EEG techniques to measure brain electrical activity have found changes temporarily associated with acute use, but no evidence of persistently abnormal EEG findings related to chronic cannabis use. So your mother was wrong. It will not break your brain. Psychopathology will make you crazy. Although this has been discussed in previous editions of this report and there is little new evidence, as the 7th edition, a reiteration of what is known may be useful to those unfamiliar with the area. The most common adverse psychological reaction to marijuana use represents an exaggeration of the more usual marijuana response in which the individual loses perspective, i.e. the realization that what he or she is experiencing is a transient drug-induced distortion of reality and becomes acutely anxious. This reaction appears to be more common in relatively inexperienced users, although unexpectedly higher doses of the drug, such as a higher potency, can cause such a response even in the more experienced user. The symptoms can generally respond to authoritative assurance and diminish in a few hours as the immediate effects of acute intoxication recede. And again, I will argue that this also has been reduced now that things are more legalized. There is less reason for paranoia. Transient mild paranoid feelings are common in users, and it has been suggested that those who are characterized by more paranoid defense mechanisms are less likely to experience other acute adverse reactions. It has been repeatedly emphasized the reactions of users are very much influenced by the set and setting of use. Set refers to pre-existing expectations individual has regarding use. By setting is meant the physical environment during use. It is generally concluded that anxiety and mild paranoid reactions are more likely if the user is initially anxious about the experience and or the circumstances of use are anxiety producing. Additional research support for this clinical impression is found in a field survey which used a questionnaire to measure acute adverse drug reaction. Preliminary work has found that in a college population, those who are more hypochondriacal and who feel less in control of their own lives and more at the mercy of external events are more likely to have adverse reactions to marijuana and other psychoactive drugs. So if you're already paranoid and freaking out, it's just going to make it worse, which I guess is fair. An acute brain syndrome associated with cannabis intoxication, including such features as clouding of mental processes, disorientation, confusion, and marked memory impairment, has been reported. It is thought to be dose-related, much more likely at unusually high doses, and to be determined more by the size of the dose than by pre-existing personality. This set of acute symptoms has not been frequently reported in the United States, possibly because until very recently, strong cannabis materials were less readily available here than some overseas locations. Acute brain syndrome also diminishes as the toxic effects of the drug wear off. Descriptions of a specific cannabis psychosis are to be found principally in the Eastern literature from cultures where use is typically more frequent and at much higher doses than those generally consumed in the United States. It continues to be difficult to interpret such reports because the diagnosis of mental illness is partly dependent upon social cultural factors. In addition, the diagnostic picture is frequently complicated by use of other drugs and earlier evidence of psychopathology not necessarily associated with drug use. While the overseas studies conducted under the United States auspices in Jamaica, Greece, and Costa Rica did not find such adverse consequences, the small size of the user sample study, together with the probable rarity of the disorder, would have made its detection unlikely. One clinical study in India has contrasted the features of a paranoid psychosis arising in the course of long-term cannabis use with that of paranoid schizophrenia. 25 consecutive patients admitted with each diagnosis were compared. The cannabis users reportedly had used the drug for 5 or more years and amounts up to several grams per day and gradually increasing quantities. Those diagnosed as having a cannabis psychosis were characterized by the authors as showing more bizarre behavior, more violence and panic, an absence of schizophrenic thinking, and a greater insight into their illness. Patients with a cannabis-related disorder recovered rapidly upon being hospitalized and being treated with a major tranquilizer. In this and other clinical studies, it is often difficult to distinguish the role of cannabis from that of pre-existing psychological problems or other environmental precipitants in marijuana-related psychological difficulties. Frequently, heavy marijuana users are also those who have had emotional problems prior to use. Trauma makes you do it, kids. Some further indication of this is to be found in a paper reporting on 4 cases of well-documented schizophrenia in which the use of marijuana is believed to have led to an exacerbation of psychotic symptoms in patients whose psychoses were in at least partial remission prior to use. The author concludes that while marijuana can perhaps be safely be used by many persons, this is not so with the schizophrenic. He urges that schizophrenics be alerted to the special hazards he feels marijuana poses for them, and in the same way other patients would routinely be alerted to possible hazardous interactions between their illness and substances they might use. In a detailed review of the relationship between cannabis and violence, the author concludes that while marijuana probably does not precipitate violent behavior in the majority of users, nevertheless, there may be some individuals with a prior history of poor impulse control or special circumstances of stress which, combined with pre-existing personality, may make use inadvisable. Yeah, I have not seen too many angry potheads. It is not clear, however, he points out, whether this is specifically marijuana, which might have the undesirable effect of releasing violence, or any of a variety of other drugs, including alcohol. Based on his experience with some 5,000 drug-related psychoses encountered while medical director of many youth festivals, one author has summarized his clinical experience, including that with marijuana users. In his experience, serious adverse reactions to marijuana are rare, but he offers several sources of concern about its widespread indiscriminate use. Specifically, he feels that the possibly unexpectedly high potency of some of the cannabis preparations may pose a hazard for those used to weaker materials. Although he believes it to be very rare, he thinks that it is possible to have a psychotic reaction to marijuana. He also believes that persistent psychiatric symptoms after psychotic drug experiences are more common than is generally believed, as many as 5 to 10% of those cases which he was able to follow up. While some patients reporting flashbacks had their initial bad trip on drugs other than marijuana, the flashback recreation of the disturbing aspects of the original experience frequently occurred following alcohol or marijuana use. He concludes by advising that those with a history of emotional disturbances, and especially bad trips, i.e. drug-precipitated emotional disturbances, should avoid intoxicants, including alcohol and marijuana. Finally, this author advises that present emergency room and psychiatric hospital procedures should be altered to make the situation less judgmental, less frightening and coercive, more compassionate, and more acceptable to youth, with more home-like and reassuring surroundings. Marijuana flashbacks, spontaneous recurrences of feelings and perceptions similar to those produced by the drug itself, have been reported. A survey of United States Army users found that flashbacks occurred in both frequent and infrequent users and were not necessarily related to a history of LSD use. Such occurrences may range from quite vivid reaction of a drug-related experience to a mild evocation of a previous incident. The origin of such experiences is uncertain, but those who have had them typically appear to require little or no treatment. One source of information about possible adverse reaction to drugs, including marijuana, is the federally sponsored Drug Abuse Warning Network. This is a nationwide reporting system which provides information about the frequency with which various drugs in common use are implicated in patient contact with such facilities as hospital emergency rooms. Those fatalities, sorry. During a one-year period beginning in May 1976 and ending in April 1977, marijuana ranked 13th among the drugs mentioned in drug-related emergency room contacts. Okay, 13th, that's pretty far down, guys. That's like all the street drugs plus some pharmaceuticals thrown in. like 13th, and we're worried about this? Okay. But during the year 1978, the most recent year for which complete data are available, marijuana had risen to 6th place. All right, moved up pretty quickly in a few years. But still, 6th place, that is not particularly high, in my opinion, like where we should be freaking out. Yeah. While such figures are not always easy to interpret, they do suggest that marijuana is not an uncommon factor in causing individuals to seek help, and that its importance may be rising, possibly because of an increase in the number using the drug, or because of the increased availability of strong materials more likely to precipitate adverse reactions. Effects of chronic use on intellectual functioning. The question of whether or not enduring effects on memory and other aspects of intellectual function occur as a result of chronic use is a difficult one to answer. While 3 more carefully controlled studies of heavy users in Jamaica, Greece, and Costa Rica failed to find evidence of this, several caveats should be mentioned. The numbers studied were small, the testing procedure of the population studied may have been insensitive to drug-induced decrements, if any, and even the mode of drug use may have differed from American use. Overall, the majority of studies have suggested impairment does occur. Unfortunately, the quality of studies in this area leaves much to be desired. Thus, the issue still remains in significant doubt, especially with reference to American users. A retrospective study of the Egyptian prison population of cannabis users compared 850 chronic users with 839 non-cannabis using controls using a number of tests of psychological functioning. Users were reported to be slower in their psychomotor performance and to show impaired visual coordination and memory for designs. These performance deficiencies were found to be more common in younger, better educated users from urban backgrounds than in older, illiterate users from rural areas. This study has been sharply criticized for the alleged sampling and psychometric deficiencies and equally sharply defended by its author. Despite the apparent disagreement on many points, there was agreement on the desirability of replicating the work and possibly doing further analysis of the original data. The large samples employed, despite some of the methodological deficiencies, might well make the original Egyptian study more sensitive to modest differences between smoker and non-smoker groups, which smaller studies may well have missed. At present, the information available does not permit a conclusive judgment of the adequacy of the study's findings, particularly if the data were subjected to the more elaborate analysis designed to take some of the criticisms leveled against the study into account. And I think my dog Quinn wants to go outside. A study of chronic cannabis users in northern India has been published based primarily on a comparison of 11 male users out of a larger sample of 23, in turn chosen from 139 long-term cannabis users, with 11 male non-users who were matched in terms of age, occupation, and marital status. Users had all used cannabis equivalent to about 50 milligrams per THC per day, about the equivalent of 5 to 10 joints of typical 1 to 2% THC content marijuana, for 5 years or more. They were given physical examinations, including various laboratory tests of blood and urine, as well as chest x-rays, electrocardiogram, and electroencephalogram. Subjects were also given a wide range of psychological tests of intelligence, memory, and other intellectual functions, sometimes impaired in the brain damaged. The physical examinations, including all but one of the laboratory tests for uric acid blood levels, which were found to be somewhat elevated in users, were normal for both users and controls. On the psychological tests, however, users did significantly less well than did non-users on 2 measures of intelligence, 9 to 11 IQ points lower for users, a measure of memory, a task requiring a reproduction from memory of geometric figures, a test of combined cognitive psychomotor speed, and a test of time perception, which all kind of makes sense if you ask me. Unfortunately, several questions of methodology, which might have had an influence on these findings, are not clear from the report. 23 users, more carefully examined, were selected from a larger sample of 139 long-term heavy cannabis users, and of these, only 11 were then matched with 11 non-users. It is not clear whether the basis for selection of the initial 23 was random or whether some non-random criteria were used, such as ready availability, willingness to be further tested, need for possible inducements to participate, etc. The authors themselves raised the question whether the impairments found in user functioning were caused by drug use or if the impairments detected existed prior to such drug use. Yeah, they argue for the desirability of doing a prospective study if the question of cannabis-related impairment of function is ultimately to be resolved. The possibility that other aspects of lifestyle, such as inadequate diet, might have played a role cannot be dismissed as a factor in the poorer performance of the users. Since users were from among the poorer groups in society, the cost of their cannabis might well significantly reduce the amounts available for food purchases. At present, the results must be regarded as provocative and should be more carefully explored. American studies comparing college student users with non-users have found little in the way of evidence of intellectual performance decrement associated with cannabis use, at least as such performance is measured by college grades. As was pointed out in previous reports, the higher levels of motivation of students in the schools studied, rather than the modest levels of use compared with that of overseas, and the possibility that those whose performance was impaired by marijuana use dropped out earlier, all admit broader interpretation of these more limited findings. Tolerance and dependence. Tolerance to cannabis, i.e. a diminished response to a given repeated drug dose, is now well substantiated. Tolerance development was originally suspected because experienced overseas users were able to use large quantities of the drug that would have been toxic to United States users accustomed to smaller amounts. Carefully conducted studies with known doses of marijuana or THC leave little question tolerance develops with prolonged use. Several more detailed reviews of tolerance development and the behavioral and physiological effects of marijuana in both animals and humans have been published. A report detailing tolerance development of 30 young adult subjects in a 94-day closed experimental ward environment has also been published, which stresses tolerance to both effects on the heart rate and subjective high. The practical implication of this work are that experienced frequent users of marijuana experience less pronounced physiological and psychological changes at a constant level of use than would less experienced users. This is in some contrast with the original impression that users had a reverse tolerance, i.e. a greater sensitivity to marijuana upon repeated use. That doesn't make any sense, but okay, sure. The latter impression probably derived from the relatively low dose, infrequent use that characterized some of the earlier observations. Under those conditions, neophyte users may have become more aware of marijuana's subjective effects with repeated use, partly as a result of social learning of what was to be expected from the experience, and thus subjectively believed that its effects were enhanced. Since marijuana's metabolites, the transformation products which result as marijuana's metabolites, are also persistent in body fat, it is also possible that repeated low-dose usage released some of the previously stored material, enhancing the effects. Whatever the ultimate explanation of these earlier impressions, under conditions of heavier, more regular use, tolerance now appears to be well established. When one turns to the question of cannabis dependence, the term has often been used in an imprecise way with meanings ranging from a vague desire to continue use, if available, to the manifestation of physical withdrawal symptoms following its discontinuance. If dependence is defined as experiencing definite physical symptoms following withdrawal of the drug, there is now experimental evidence that such symptoms can occur at least under conditions of extremely heavy research ward administration that are atypical of social marijuana use in the United States. The changes noted after drug withdrawal under these experimental conditions include one or more of the following symptoms. Irritability, no shit. Restlessness, yep, you ain't got nothing to smoke. Decreased appetite, yeah, smoking makes you hungry. Sleep disturbance, yeah, you can't sleep as easy. Sweating, yeah. Tremor, nausea, I don't really think so much tremor and nausea, but okay. Vomiting, diarrhea, okay, I don't believe that either. Some of these symptoms were experienced in a similar research study by users who selected their own marijuana doses. Such a withdrawal symptom has thus far been reported clinically in only one formal research report. Okay, therapeutic aspects. A fringe benefit of the past decade's marijuana research has been a renewed interest in its potential as a therapeutic agent. As earlier editions of these reports have indicated, cannabis has a very ancient history of use for the treatment of an unusually wide range of human ills. Almost from the dawn of history, cannabis has been used in many parts of the world as a pharmaceutical preparation. As recently as 1937, tinctures of cannabis were still listed in the United States Pharmacopoeia and presumably used therapeutically in the United States. One limitation of these earlier preparations was the extreme variability of drug potency, ranging from inert or nearly so to unexpectedly potent. Renewed interest in the potential usefulness of cannabis or some synthetically related drug has led to experimentation with these drugs for a wide range of symptoms and disorders. Although several of these applications have shown promise, much remains to be learned about even the most promising applications. Control of nausea and cancer chemotherapy. Use of marijuana, THC, or related drugs for the treatment of extreme nausea and vomiting, which often accompany cancer chemotherapy, is probably the single most promising application of these drugs. While by no means invariably effective, they are sometimes valuable when other standard anti-nausea drugs are not. One of the earlier studies, done in 1970, found that THC-treated cancer chemotherapy patients showed improved appetite and diminished weight loss. A subsequent study done in Boston found that when compared with a placebo, that is, an inert substance, in a double-blind study in which neither patients nor physicians knew what drug was being administered, THC had an antiemetic effect in 7 out of 10 patients. The placebo-treated patients showed no improvement excuse me, In one recent study of 15 patients receiving methotrexate for their bone cancer, THC or placebo was randomly assigned. 14 of the 15 patients showed improvement following the use of THC. The amount of reduction in nausea and vomiting was closely related to the dose of THC given. At the highest THC dose employed, in 6% of the treatment sessions, patients experienced nausea and or vomiting, compared to 44% when half the dosage was used. Such adverse symptoms were found in 72% of the sessions in which the pharmacologically inert placebo was employed. In a second phase of the same experiment, 4 patients who had shown excellent therapeutic response in the first phase were again treated with THC, but this time much less favorable results were achieved. The reasons for this are unclear, although the author suggests the possibility that these patients developed a tolerance to the effect during the first phase of the experiment. Other studies have attempted to compare marijuana-related drugs to other standard anti-nausea medication to determine their relative effectiveness. Metabolism, a drug chemically related to marijuana constituents, was compared to prochlorperazepine, a standard anti-nausea drug, in a series of 113 patients receiving cancer chemotherapy. 80% responded to Nabilone, compared to 32% who responded to prochlorperazine. Use of this experimental drug, however, has since been suspended because of toxic effects observed in dogs. And yeah, we are so totally related to dogs. Okay. A partial analysis of the response of the first 66 patients of a series of 200 receiving prochlorperazepine and THC in experimental design in which each patient received trials of both found that equal numbers, 25, preferred each, 12 had no preference, and 4 patients did not respond to the question. Sleepiness was the most common side effect of both drugs. Overall, marijuana, THC, and related drugs show promise for treating the nausea and vomiting, which are common side effects of chemotherapy. Although thus far THC and marijuana do not appear to be invariably superior to other medication, they may be useful with patients for whom other drugs are relatively ineffective. Glaucoma! A second treatment application, which has received wide publicity in the mass media, is to reduce the vision-destroying intraocular pressure which occurs in open-angle glaucoma. This use is based on the original observation, both in normal young men and in test animals, that such pressure reductions occur. Initial trials with oral THC alone found the drug to be a variable success. When used as a supplemental drug with other standard intraocular pressure-reducing drugs, greater success was achieved. Because of the desirability of developing a more convenient dosage form with fewer side effects, an eye drop preparation has been tried. Although it showed initial promise in reducing intraocular pressure in rabbits, it produced eye irritation, was ineffective to humans in one trial. Additional human testing is planned. Yeah, I can see why that would get canned. Anything with burning to the eye is like a no. A recent study employing smoked marijuana with 16 glaucoma patients, 8 of whom were hypertensive and 8 of whom were not, found that the hypertensive patients showed a significantly greater drop in eye pressure than did those with normal blood pressure. At present, marijuana-related drugs have been shown capable of reducing intraocular pressure in people with glaucoma alone in combination with more conventional anti-glaucoma medications. However, the long-term safety and efficacy of marijuana-related drugs administered chronically to glaucoma patients has not been established, nor is there any data from long-term controlled studies to demonstrate whether these preparations can actually preserve visual function in such individuals. As with other clinical applications, a synthesized drug with fewer of the side effects found with the natural material may ultimately be more useful. Continued clinical trials to determine the most useful combinations with other drugs could be desirable. Yes, we have to, of course, make it a synthesized drug that, of course, Big Pharma can, make some money off of. Other therapeutic uses. A variety of other clinical uses of marijuana have been suggested or experimentally employed. While marijuana's ability to dilate the lungs' air passages, bronchodilation, has been thought to have promise in treating asthmatics, the drug's lung-irritating properties seem to have offset this potential benefit. Aerosol preparations for inhalation have shown some promise, but have produced lung irritation and may not be commercially feasible. Despite these problems, a marijuana-related drug may still prove to be of a limited usefulness, since its different mechanism of action from that of conventional drugs may make it useful to some patients with whom other drugs are ineffective. The paradox that THC and marijuana have both convulsant and anticonvulsant properties has led to both to a concern about the implication of marijuana use by epileptics and a speculation about its possible value in controlling seizures. In animal experimentation, these drugs have reduced as well as increased seizure activity depending on how the experiment was conducted. As in the treatment of glaucoma, the possibility that one or more of marijuana's constituents may be useful in combination with other standard anti-seizure medication exists, although its usefulness, if any, appears limited at this time. Although a small survey of youthful epileptics did not disclose any particular effect of cannabis use upon their seizure patterns, our present limited knowledge and the possibility that marijuana might adversely affect these patients suggests that caution be exercised in use. While there have been some clinical reports of marijuana reducing muscular spasticity in paraplegics and patients with multiple sclerosis, such work is still in an early stage with a definite usefulness has not yet been found on a more systematic basis. Still, other applications of marijuana in the treatment of depression, pain, and alcoholism and drug dependence have been variously considered. Although these applications have not been adequately explored, there is little evidence that they are likely to prove useful at this time. While marijuana and/or synthesized constituents have shown some promise as therapeutic agents, it should again be emphasized that additional work is necessary before such agents become generally approved as standard medications, even for limited purposes. If consistently useful medical applications for marijuana are found, it is quite likely that the product or products resulting will be chemically related to, but not identical to, the natural material's constituents. Hello, God, what was that pill? I used to give my friend who had really bad cancer, because you're not supposed to be smoking. And of course, now I can't remember it. If you can remember it, put it in the comments if you've been hanging out this long. Whether or not cannabis, one of its synthesized constituents, or a chemically related compound, once again finds a place in modern medicine depends on several considerations. One problem is that pharmaceutically desirable effects may not be persistently useful for the chronic disorders. Tolerance undoubtedly develops for a number of the effects of the natural material. This may also be true for new chemically related compounds. Like any other new medication, chemically related materials must be carefully tested for toxicity and for therapeutic effectiveness. This process is time-consuming, and many new pharmaceuticals showing initial promise are ultimately discarded as unanticipated drawbacks and limitations to their use arise. All right, I'm going to try to finish this, so hang in there with me if you've already hung in for the last 30 minutes of this part 3. Effects of marijuana in combination with alcohol and other drugs. Since marijuana is so commonly used in combination with alcohol and other drugs, the combined effects of these drugs has potentially important implications. Given that the extremely wide range of possible doses and interaction, it's not surprising that our present knowledge is still quite limited. This is true even of the most commonly used combination, alcohol and marijuana. A related issue is the extent to which marijuana use might displace alcohol use were both drugs equally available. Although some marijuana use in the 1960s were ideologically opposed to alcohol, it now appears the use of both has generally increased. While it is not possible to be certain what would occur under conditions of equal availability, there is no indication that increased marijuana use among teenagers and young adults has resulted in a decrease in alcohol use. Not yet. Give it another 20 years. In fact, several researchers have noted a positive correlation between heavy marijuana use and that of alcohol. People like to party. That is, those using marijuana heavily are more likely to use alcohol than those who did not use it or use it less frequently. One large-scale longitudinal study of children from elementary school to high school age has found that the early use of alcohol and tobacco is more common in those who also begin marijuana use early or use it more regularly and heavily. In one study of marijuana use in young men conducted in a closed experimental ward setting, marijuana smoking increased regardless of the availability of alcohol, although conversely, alcohol use decreased when marijuana was available. Thus, the larger question, what would happen in American culture were marijuana more freely available, cannot readily be answered. It might well depend on the kinds of informal social attitudes and controls which have developed among users. Animal studies, the behavioral effects of the alcohol-cannabis or THC-alcohol combination have generally found that the combined effect is greater than that of either alone. That makes sense. Alcohol is like that with many things. For example, the duration of alcohol-induced sleep increased as much as threefold when rats or mice also received a marijuana extract or THC prior to being given alcohol. Animals receiving THC in doses that ordinarily did not interfere with their ability to remain on a moving belt showed increased alcohol-related impairment of their performance. When animals have been simultaneously administered both drugs, continued avoidance, i.e. a learned avoidance, of a noxious stimulus, general activity level, heart rate, and body temperature have been more affected than when either was used alone. The limited human research to date is generally consistent with the results of animal research. Experiments with alcohol levels in the range of commonly used socially show that performance reductions from combined use are greater than those from the use of either alone. Such decrements have been detected in reasoning, manual dexterity, and standing steadiness. Although the effects after 40 minutes were greater than either drug separately, 2 hours and 40 minutes later, some of the changes were less than those of THC alone. This apparently antagonistic action under some circumstances may result from the different rate at which the two drugs are metabolized. In more recent experiments, when alcohol was given 1 hour after THC, the effects of the drugs were clearly additive. Combined use reaction time, cognitive performance, standing steadiness, and psychomotor coordination more than that of either alone. In measuring glare recovery, the time it takes for light adaptation after exposure to bright light, it was only slightly greater from the combination than for either alone. The authors of a research paper dealing with the side effects of alcohol and marijuana caution that the use of the two simultaneously may be dangerous for those with cardiac disorders. In a study of 7 healthy male volunteers aged 20 to 29, they found that 4 of the 7 developed intense nausea and vomiting when they smoked a marijuana cigarette after drinking a moderate amount of alcohol. The doses of alcohol involved: 1 gram of ethanol per kilogram of body weight, or about 0.57 cc of pure alcohol for an average man weighing 154 pounds, represented the equivalent of 3 drinks containing 1.5 ounces each of 90 proof liquor. All 4 men were markedly incapacitated during the height of the adverse effects, although they recovered in 3 to 4 hours. The fact that not all 7 subjects were equally affected illustrates the large individual differences in response. One subject, for example, experienced a marked drop in heart rate under the influence of the drugs from 150 to 36 beats per minute. While the experiment was repeated with half the amount of alcohol originally used, no adverse effects occurred. The volunteers acknowledged that similar adverse consequences had sometimes occurred when they had used the drug recreationally. Taking the total of animal and human research, simultaneous use of both alcohol and marijuana typically has more profound effects than use of either alone. However, the magnitude and duration of the effect may vary depending on the dosages of the 2 drugs involved, the type of effect measured, and the time intervals involved in administering the drugs. As with either drug alone, there are also undoubtedly individual differences in response to the drugs in combination. Animal research has raised the question of a possible cross-tolerance between alcohol and marijuana. By this is meant regular administration of one drug may result in a decreased response to another drug, even though the other has not been given. A recent experiment has found that when both alcohol and THC were administered to rats, they developed tolerance to alcohol much more quickly than when they received only alcohol. In humans, the question of cross-tolerance has not yet been resolved. While there is still some evidence that the performance of male heavy marijuana users is less affected by drinking 4 to 5 ounces of 100-proof alcohol than is that of non-users, a later study of performance under similar conditions found the trend to be statistically insignificant. That is, the difference found may well have been the result of chance rather than due to prior marijuana use. There have been few human studies of the interactive effects of marijuana with drugs other than alcohol. However, limited evidence suggests that such interactions may be significant. A study in which high doses of THC were given to young adult males indicates that chronic marijuana use may affect the persistence of barbiturates in the body, as well as the rate of absorption. Only limited studies of the combined use of amphetamines and marijuana in humans have thus far been done. One study found that simultaneous use resulted in an increase in the intensity and duration of the subjective high, greater than the use of either alone. The possibility that absorption, distribution, metabolism of therapeutic drugs might be modified by marijuana use has been raised. In rats, aspirin has been found to decrease the rate of disappearance of THC in their blood, as well as to increase the THC in brain levels. Since then, there are many therapeutic drugs in widespread use, which are used in many different forms and dosages, and much work remains to be done. Alright, the hazards of marijuana versus other recreational drugs. A question that frequently arises is how hazardous is marijuana compared to alcohol and tobacco? As appealing as such a comparison is, it is also misleading on several grounds. Any comparison of alcohol and tobacco use and that of marijuana compares drugs with great differences in social acceptability, period of use, and degree of availability. The hazards of alcohol and tobacco are reasonably well known, and the social and public health costs quite high. For example, fully 10% of alcohol users have been described as having an alcohol problem, and alcohol has been implicated in half the automotive fatalities in the United States. The health costs of alcohol in terms of cirrhosis, mental illness, crime, and industrial accidents can also be documented. A similar analysis can be done for tobacco. By contrast, marijuana has only recently become a popular substance, remains illegal in most uses, not habitual or present. Moreover, unlike cigarettes and alcohol, for which the health hazards can be reasonably well specified, much less is known about the implications of marijuana use. Any consideration of the hazard a drug poses must take into account not only its present use, but also use that might be reasonably expected in the future. At present, this involves many imponderables, such as the parameters of risk for various groups in our society at different levels of use, the likely circumstances of use, effects on user functioning and motivation of heavier use patterns, degree of restriction possible, combined use with other drugs, to name but a few. As the history of the introduction of alcohol demonstrates, it is very difficult to anticipate the problems which will arise in a given society in advance. Thus, any attempt to compare the health impact of marijuana with that of alcohol and tobacco at current levels of use is certain to minimize the hazards of marijuana. Okay, okay. That's a good way of getting out of things, government report. But any comparison at levels of anticipated use involves many assumptions that are at best dubious and at worst may be dangerously misleading. Such a comparison seems therefore useless and undesirable until such times the parameters of risk are better specified than they can be at present. Future directions. In the past decades, a priority emphasis on federal marijuana research has brought about an impressive increase in our knowledge concerning cannabis and its effects. Our understanding of the basic chemistry of marijuana, its mode of action in the body, and some of the acute and chronic effects of the drug have all expanded rapidly. Nevertheless, there are still many areas in which our knowledge continues to be modest. For example, we know little about the implication of use by girls and women, both for their own health and for possible offspring. Since nearly half of the American users are females of childbearing age, this is an important area for further research. As marijuana use has come to include much younger ages, a decade ago use was largely restricted to young adults. Now significant numbers use in their early teens. The need to understand the implications of use by this group has also become imperative. Unfortunately, teasing out the effects of marijuana from that of both other drugs and other aspects of lifestyle is not always easy. Heavier users of marijuana at any age are more likely than non-users or light users to take other drugs as well. As we have seen, street marijuana can also vary in potency from inert or nearly so to material with high THC content, which is very psychoactive. While carefully controlled animal experimentation, which factors are as disparate as genetic and learning history can be specified, is very useful, and there are important differences between animals and humans. While marijuana, for example, slows heart action in most animals, in humans it accelerates it. And while significant progress has been made through special apparatus to induce animals to smoke the material, it is not easy to replicate typical conditions of human use. Now that must be a fun job. As a research scientist, building various apparatus to trick animals into inhaling a contact pus. Well, I guess it's not contact pus. Anyway, I'm sorry, just picturing the engineering for that. That cracked me up. All right. National Institute on Drug Abuse, the agency within the Department of Health, Education, and Welfare, which is principal responsibility for marijuana research, makes repeated use of non-government scientists serving as consultants to assist in determining new directions for research. One of the central questions that has been considered is the desirability of conducting large-scale, long-term epidemiological studies analogous to those which are done to determine the effects of cigarette smoking. Because the level of marijuana use for most of the population has been modest, and because the potency of the material has been so variable, this approach is unlikely to produce results in proportion to its high cost. Indeed, the Institute has elected to support a large variety of smaller studies focusing on some of the already identified specific effects, as well as exploring implications of use in high-risk groups. Following the recommendations of its consultants, NIDA is particularly concerned with studying the implications of use during periods of likely maximum sensitivity. These include childhood, adolescence, and prenatal development. The study of groups receiving standardized health care is being investigated to determine cost-effective means of doing larger-scale studies likely to detect effects in children, adolescents, and young adults. Development of standardized data collection methods, which will enable researchers to effectively pool data from several sources, is also being pursued. This enables us to detect use implications in pulling samples larger than are available in any single study. Such standardized methods also make it possible to compare data from different sources. Because of the increasing importance of multiple drug use patterns, the implications of that type of use are also being studied. While simultaneous use of alcohol and marijuana is the most common pattern, many users use the drug with other licit and illicit drugs. Such pattern of the use and their implications must be explored. It is unlikely that any single approach will be sufficient. Methods that diversify the study of impact of marijuana's constituents on cell membrane metabolism to psychosocial research on changing patterns of use are all essential to developing a well-rounded picture of the implications of marijuana use. It is also unlikely that any single piece of research will provide the definitive answers to our concerns about marijuana's effects. As with other drugs, it is probable that our understanding will increase gradually and the effects of the drug will not be uniform, but will vary significantly depending on the age, mental, and physical health of the user and the individual differences in vulnerability to the drug's effects. Frankly, given the marked increase in use by children and adolescents, it is important that we develop a more effective means of discouraging use. Hello, Dare. While more progress has been made in this area, much more needs to be learned about individuals and groups at high risk becoming seriously involved with marijuana use. Through an improved understanding of the factors which play a role in individual vulnerability, we may ultimately be better able to target prevention efforts towards those most likely to suffer serious adverse consequences rather than a more general population. An important step in the ongoing process of exploring the implications of cannabis use and the best ways of coping with it is an independent review of the marijuana area being sponsored by the department to be conducted in 1980. This review will provide a fresh look at our present knowledge and possible future directions of effort. It will encompass research into the physiological effects of marijuana as well as behavioral research into such use-related problems as intervention strategies to help adolescents resist peer pressure. Yep, DARE. DARE. We created DARE. It was a time. A report is expected to be produced in about 1 year. Addendum. Okay, at the time of completion of the 8th Marijuana and Health Report, the 1979 National Household Survey had not yet been completed. The following addendum is a brief survey of this most recent national survey, which was released on June 20th, 1980. As has been consistently true since the National Survey was first conducted in 1972, marijuana use is highly correlated with age. This past year, 8% of 12 to 13-year-olds reported some experience, but by ages 14 and 15, the percentage who had used it increased to 32%. A simple majority, 51%, had used it by ages 16 and 17. Peak use was found among 18 to 25-year-olds, a group in which over two-thirds, 68%, had tried the drug at some time in their lives. Taking the 12 to 17-year-old group as a whole, the percentage that ever used marijuana had more than doubled since 1972, from 14% to 31%. Among young adults, 18 to 25-year-olds, the increase was smaller, from 48% in 1972 to 68% in 1979, a significant increase from 60% in 1977. Current use, as defined use as within the month preceding the survey, is also markedly age-related. For youth 12 to 17 and young adults 18 to 25, about half as many currently use marijuana as ever used. Thus, 16.7% of youth currently use marijuana, a figure unchanged from the 1977 survey, but also more than double the 7% of this age group that reported then current use in 1972. 35% of young adults were currently using it by late 1979, a figure nearly a third larger than that of 1977. Until this past year's survey, current use was consistently between 25 and 28% for all survey users from 1972 to 1977. For older age groups, that is those over 26, both lifetime prevalence and current use are markedly lower than that for younger persons. Nearly 20% of older adults ever used marijuana by 1979, compared to the 7.4% when marijuana experienced in 1972. Current use by this age group has risen from 2.5% in 1972 to 6% this past year. The percentage of older adults reporting current use has nearly doubled since 1977, 3.3 to 6%. As figures indicate, while there have been marked changes in all age groups since 1972, statistically significant changes, i.e. changes not likely to be the result of chance, between 1977 and 1979 were confined to the young adult and older age groups. Youthful use was unchanged from 1977. I don't know, to me this kind of makes sense because you try it and then you like it and you get a few more people, but it's not enough to really tip the scale. This year's survey, for the first time, included questions about perceived hazards of marijuana use. It is noteworthy that only 5% of the peak-using 18 to 25-year-old group saw the drug as having no bad effects. Perceived adverse consequences range from performance and health impairment to possible psychological effects and increased likelihood of using stronger drugs. Nearly three-quarters, 72.2% of young adults believe that being high causes impaired driving performance. 1 in 8 young adults felt it would not. These observations on perceived hazards should serve as a useful baseline for future comparisons. And we have hit the references, so thank you for hanging in this long, because the third part is exceedingly longer than possibly the first two. I don't know. Anyway, we did learn some interesting things buried way down deep in there. There's a nice little nugget about THC and cancer. Did you catch it? I caught it.